Hello friends, this is Sudharshan and in this episode we will talk about the chapter Retina part 1. So in part 1 we will be discussing about retinitis pigmentosa, retinal detachment, photoretinitis or solar retinopathy and retinoblast. So coming on to the first one, that is retinitis pigmentosa. So this is a sporadic condition which is autosomal dominant and it is one of the most common retinal dystrophy because of cis23 rhodopsin gene mutation. The pathology behind the disease is that there will be photoreceptor cell death by apoptosis and genetic mutations. So basically whatever the retinal rods and cones are there, that will be destroyed because of apoptosis or genetic mutations. So what are the clinical features? So whenever the rods and cones get destroyed, vision of the patient will be affected. So visual acuity, color vision, then visual evoked response will be decreased. Then apart from that, fundus fluorescein angiogram and optical coherence tomography will be decreased, showing decreased retinal circulation time. Electroretinogram will be decreased, showing B wave amplitude decrease. Electrooculogram will be subnormal, but these are the 4 important features we have to remember when it comes to retinitis pigmentosa. So that will be pigmentary bony spicules, waxy optic pallor, ring-like scotoma and tubular vision. And when it comes to the types of pigmentation, we have sign pigmento, sectorial, pericentric and punctata albicans. So that is basically depending on whether the pigmentation is present or not. If pigment is present, it may be in one part or one segment or surrounding the field of vision, it might be there. Or sign pigmento where there is no pigmentation at all. So treatment will be vitamin A, laser photocoagulation, good diet and low vision aids. Coming to retinal detachment. So there are 3 types of retinal detachment: tractional, rhegmatogenous and exudative retinal detachment. So we will see. First, rhegmatogenous, also called as primary retinal detachment. We don't know the cause. Very common in males who are 20 to 40 years old. So mostly it is thought that there are some breaks or destabilization in the epiretinal membrane. That is why the retinal detachment is happening. So probably it is maybe pressure from the vitreous gel which is pushing the epiretinal membrane to break off. And when it comes to tractional, it is the vitreoretinal tractional band. Please differentiate here. Vitriofoveolar tractional band is damaged in diabetic retinopathy, but this is retinal detachment. We are referring to vitreoretinal tractional band. And exudative, that is because of any pathology, like it could be a foreign body, it could be ocular trauma, it could be uveitis or endophthalmitis or panophthalmitis may be the reason for exudative. So in of rhegmatogenous, tractional and exudative will differentiate the symptoms, signs and everything. So when it comes to the regular symptoms like sudden onset floaters, vision loss, photopsia, all these are seen in the rhegmatogenous. Along with that, the tobacco dust and posterior vitreous detachment as well. And when it comes to the configuration, all the 3 are convex except the tractional. Tractional is concave, rest of the 2 are convex. And mobility will not be seen in exudative type, only rhegmatogenous and tractional. Opposite for shifting fluid, which is seen only in the exudative type, we can see. So these are the differences in the retinal detachment. And when it comes to the treatment, rhegmatogenous and tractional, it is to repair the vitreoretinal tract, stabilization of the vitreous gel using vitreous substitutes or pars plana vitrectomy. Apart from that, laser photocoagulation and cryotherapy or panretinal photocoagulation. When it comes to exudative, we have to treat any underlying cause, whatever I've listed out. And next about the photoretinitis or solar retinopathy. So as the name suggests, this is a damage to the photoreceptor cells because of excessive sunlight exposure. So here as well, just like in retinitis pigmentosa, the rod cones will be damaged, but this is more of an external factor. So apart from having sunlight, we can also have welding arc exposure as well. So when we see on ophthalmoscopy or fundoscopy, we can have a ring-like scotoma. As I told in glaucoma itself, the scotoma always comes spot to the nasal horizontal meridian. So this is how the scotoma will be there. So whenever there is a scotoma, tubular vision will be there. There will be distortion of the images, what I call the most important term, that is metamorphosia. And there can be sometimes a yellowish white spot area as well. And treatment as such, it's not there, but what we can do is advise patients to wear sunglasses and take special precautions while watching the solar eclipse. And last but not the least, we have retinoblastoma. So this is one of the most intraocular tumor which also causes papilledema. So this is an autosomal dominant sporadic condition where there is a loss of heterozygosity in the chromosome 13q14. So there is something called a Knudsen two-hit hypothesis which suggests that both the alleles of 13q14 are needed for the chromosome to be mutated and cause the tumor. So there are 4 stages in this tumor. We have quiescent, glaucomatous, extraocular and metastatic stage. So quiescent stage, it will cause basic symptoms, intraocular symptoms like strabismus and vision loss, sometimes even nystagmus as well. So when it comes to glaucomatous stage, there will be increase in IOP, because of which there will be pains, there will be severe eye pain, headache, diplopia, blurry vision, nausea, vomit, and sometimes corneal opacity, uveitis, proptosis, exophthalmos. All these can happen when the IOP pressure is building up. Then when it comes to extraocular, so from intraocular it spreads outside the eyeball in the orbital socket. So it will invade all structures of the orbital socket. Like you have the nerves, the 5th nerve causing retroorbital pain. You have the orbital vessels which can lead to ecchymosis or periorbital edema. And the tumor is metastatic. So blastoma, so that means the tumor spreads, malignancy is there. Like most common sites, you can say lungs, liver, bone and the brain. These are the 4 most common sites. When it comes to diagnosis, we will do a physical examination of the extraocular movements, or I mean to say the eye. And on labs, we will see elevated LDH, haptoglobin, and yes, we can do an imaging, that is X-ray, CT, MRI of the brain or orbit. And we can do a metastatic workup. If lungs are involved, lung function test and chest X-ray, liver ultrasound or liver function test, bones is there, DEXA calcium, the serum calcium phosphate levels, PTH. When it comes to brain, I already told CT, MRI. Treatment is surgery with chemotherapy and radiation therapy. Biopsy can be done also for the tumor, though generally for malignancies it is contraindicated because it's believed that it will spread and aggravate the tumor more. Apart from that, cryotherapy, laser or pan-retinal photocoagulation, chemotherapy drugs mostly given here are vincristine, vinblastine, dacarbazine, etc. And when it comes to the gross and microscopy of the tumor, grossly, if we dissect out the eyeball, we can see it is an endophytic mass that invades into the optic nerve. And microscopically, we can see that there will be undifferentiated tumor cells. I would also call it pleomorphic, a better term. Then we can capillary structures, that is, we can have the Flexner, Wintersteiner and the Horner-Wright rosettes. So Flexner, Wintersteiner are the true rosettes, Horner-Wright rosettes are the pseudo rosettes, which are nothing but the neurofibrillary structures, and one part of the biopsy will see the retinal tissue. So that is about the part 1 of this chapter. So thank you so much. We will see in the next lesson.